health literacy, a component of health promotion for MAT patients and providers, and to appreciate our role as advocates, both for our patients and for ourselves and our fellow providers. How this topic came to be is that, I had kind of reflected at some point that patients often ask, am I going to have to be on this medication for the rest of my life? And that we can either, push back on them that they don't understand it's a progressive chronic lifelong disorder and, what are they thinking? Or we can look for, where's something that we can work together on? For me, it's that this is a patient that's perceiving they have a rest of their life. They have life that they're going to go on and live, and they're interested in how that's going to be. Often from that discussion will come the idea that, well, some people choose to stay on medication-assisted treatment because that's what's good for them, and they'll even get to the end of their lifespan and die on MAT, but not because of MAT. They're having most likely a longer life and a happier life because of MAT, and something else is catching up with them. But we know that the lifespan for patients with opioid use disorder and for substance use disorder in general is shorter than that of the general population from two directions. The one is people having an untimely, early, tragic death from an overdose. And the other is people dying prematurely, often because a health problem that would have been preventable or treatable if found at an early stage hasn't been found or prevented because they haven't had an opportunity or the energy or organization to be able to address it. So then I thought, well, we ought to talk about what are those global health needs of patients in medication-assisted treatment. So we were going to call this health maintenance in patients with in patients on MAT, but instead we called it health promotion, and that gave things a little bit of a different spin. From my time as a medical anthropology student, I knew health promotion is actually a thing, and I thought, well, why don't we go with that and look at what does that mean to promote health for these patients? So here we go, and hopefully it's not going to be too philosophical.
Oh, no.
Let's see.
Can you click on the slide?
Oh, our advancer has,
Oops.
okay, so here we go. Now we're getting to what, I'm working now. What is health promotion? So health promotion is actually a thing. It's a kind of concept that originates from the World Health Organization. And what it is, it's a process that enables people to increase control over their own health, covers a wide range of social and environmental interventions that are designed to benefit and protect individual people's health and quality of life by addressing and preventing the root causes of ill health, not just focusing on treatment and cure. So I thought, well, that seems to be a kind of concept or a way of organizing that would be helpful for our patients. There's a variety of ways to think of health promotion, but this is one that's out there and fairly common. The simplest one is to think that there are three components. One is good governance for health, so that that people are living in the context of a government that prioritizes policies that prevent people from becoming ill, protects them from injuries, and helps them with managing their illnesses. A second component is health literacy. That's the ability to get access to read and to use and to understand health information that enables people to get the healthcare services they need and to make choices about their healthcare. And the third component is healthy cities. I thought, well, that's kind of strange. What about all those rural people? I think in World Health Organization language, there's a whole separate part of the World Health Organization that deals with rural health, but the concept still applies wherever people are. What a healthy city is a place that gives people access to the natural world and to those kind of environments that help them to do healthy things and to have healthy behaviors, and also gives them access to things that they would need and services that they would need to acquire health and to maintain good health, including availability in their community of primary care health facilities. So if we think now, what healthcare services are needed by patients with opioid use disorder? Some of these are ones that we talk about frequently and that we're very familiar with. Others may be more familiar to some of us and less to others, depending on what our scope of practice is, either for us personally or of our agency where we're working on, we're coming into contact with our patients. So, if we think first about overdose prevention, that's that, do you have Narcan, do you have naloxone, and doing the kind of testing for fentanyl or ways for patients and for us to help people to have the knowledge they need not to overdose. And then to think about infection prevention also. That's all those harm reduction interventions, like helping people to have clean needles, helping people to get access to immunizations, even if they are currently using. Then we can think about medication-assisted treatment as part of those healthcare services that are needed, and to think in a first things first way. If people don't have their substance use disorder treated, it's much less likely that they're going to be able to have what they need to go on to get health maintenance for themselves, and then to have assessment and treatment of other illnesses that they would need to address. Even when people are interested in that treatment, they're interested in treatment for their hepatitis C, they're interested in treatment for their chronic pain, and active substance use disorder gets in the way so much that that often it's, they never are able to really address those things that are important for themselves. Health maintenance is the topic that we're going to focus on. When we think about those comorbidities where people know that they're sick or find out that they're sick, we can think about a couple of different categories of those comorbidities. Chronic pain being an important one for our group, and then those heritable and environmentally influenced disorders like hypertension, diabetes, substance use disorder is one of those also. Other diseases that are maybe more rare or less commonly encountered. And then to think of complications of opioid use disorder itself, and those can be medical, surgical, psychiatric, and dental. When we think about what is required of us as we're taking care of these patients, it's pretty well spelled out in, our Ohio Revised Code 4731-3303. And this is the verbatim discussion about what do we need to do when we are assessing and managing the health of our patients. This is what it says. The physician who provides office-based opioid treatment shall perform and document an assessment of the patient, and the assessment has to include the following: a comprehensive medical and psychiatric history, a brief mental status exam, to determine the person's not actively psychotic or suicidal and that they're able to follow instructions and complete our treatment agreement, informed consent, a substance abuse history, family history and psychosocial supports, appropriate physical exam, urine and drug screening or oral fluid screening, a pregnancy test for women of childbearing age who are able to bear a child, like who haven't had a hysterectomy, and then reviewing the ORs, testing for HIV, hepatitis B, hepatitis C, and consider testing for patients who would be at risk for tuberculosis and sexually transmitted diseases in patients with known risk factors. So the things that are jumping out in red are parts that would have an impact on other parts of the patient's health besides just having them come into our program, determine that they are candidates to get office-based treatment, and then going ahead. Because we're not, kind of buprenorphine dispensing robots. We're thinking about other aspects of our patients. This is what is required. And you can already be thinking, wow, what does comprehensive mean? And am I really doing that? But here is the next part. MAT providers must provide a naloxone kit or availability of one or offer one to the patient. I am often hearing patients say, I already have one of those and I know where to go, and I know it expires and I'll get a new one, which I'll document. Sometimes they'll have a prescription for me, or sometimes they'll say, well, I know where to go to get it. So that's a must. Another set of musts is the toxicology test for drugs and alcohol, appropriate history, substance abuse history, and a pregnancy test. Otherwise, states 4731 in section B2, the physician may satisfy the assessment requirements by reviewing records from a physical examination and laboratory testing of the patient that was conducted within a reasonable period of time prior to the visit, which really means if our scope is we really are focused on providing that office-based buprenorphine, and we're not going to be doing a lot of comprehensive assessing and testing otherwise, that's okay as long as someone has done it and passed those records on to us. Here's what's missing. There's no requirement for assessment of other comorbidities beyond that report in the history, even if we have gotten a good comprehensive history and physical exam from wherever the person's being for medically supervised withdrawal or hospitalized or so on. There's no requirement for us to take items that we found in that test and to have that patient get some coordinated care for those things. There's no requirement for us to review a patient's health service needs, and coordination of care is not required except for the psychosocial component of the buprenorphine treatment program in that first year of treatment. And obviously we can do better than this without overtaxing ourselves or distracting from what we really are trying to do with the patient. As Dr. Chambers mentioned earlier, one way is just to start by ensuring that the patient has primary care accessibility. We can't, like for many interventions with a patient, we can offer those things and help to facilitate and make it easier for that person to get those interventions. We can't force that person to get that intervention or take them by the hand and lead them over there, but we certainly can make it easier for the person. We can, in a health literacy way, give them the information they need to think, oh, maybe I really should get a primary care doctor, even though all of my healthcare problems I think are really caused by my addiction. There might be some other healthcare that I would need and that I'm entitled to and that I should be getting. So if we think about what does primary care provide, provides preventive care, immunizations, which are important in our group, chronic illness education and assessment and care for chronic illnesses, and then a backup for all of the counseling and other kinds of ways that patients might go about making some modifications to their lifestyle. And if you're going from the lifestyle of a kind of heroin using person to any kind of different lifestyle, there are going to be a lot of changes there. Smoking cessation, nutrition, sleep hygiene, exercise and activity, and stress management are all kind of natural things for a primary care doctor to bring up. If your primary care physician is a family doctor, then the patient might have an option to also bring their children to get care with that same doctor, which opens up a lot of other ways to talk about substance use disorder and health when you have a kind of multiple family members. If we look at what kind of preventive services our patients should have, we might think within our own settings, we're not going to be providing those services, but that it might be interesting at some time for the patient to know that these are services that they should be acquiring, and for us to help them to find a way to get these things that are standard preventive care measures for any adult under 65. So these fall into kind of categories. There's cardiovascular risk assessment, if patients have hypertension, hyperlipidemia, obesity, checking on whether they have optimal physical activity, and if they have diabetes. Those are all kind of areas that can be discovered to help mitigate cardiovascular risk. Smoking cessation has its kind of own category down in psychosocial concerns, but it's also a cardiovascular risk. Cancer detection for breast, cervical cancer, colorectal, lung, prostate, and melanoma. These are all cancers that have screening that is helpful to do. Immunizations, adults should all have a flu shot. They should have a Tdap, and they should be immunized for varicella or for zoster if they're over 50. Selected patients should have a pneumococcal vaccine, but that's almost all of our patients who are smokers and who have pulmonary risks. And then patients can be immunized against human papillomavirus up to age 26 for women and men who have sex with men, and up to age 21 for other men in a way that is going to be covered by their Medicaid type insurance. Hepatitis B and then hepatitis A immunizations, especially for people who have hepatitis C antibody positivity, to help them not to acquire a different hepatitis to further insult their liver. Then we can think about sexually transmitted infections and bloodborne infection detection. These are, again, screening tests that in selected patients are going to be helpful. Osteoporosis, mostly for older people, but for some younger people with risks, and these psychosocial concerns. It's worthwhile to screen every adult every year for depression, and to screen for alcohol, nicotine, and other drug problematic use, and to screen for intimate partner violence. So there on one slide is all of the kind of group of preventive interventions that are effective to do and to use. Here is the same interventions with some extra stuff on a one-page handout. Of course, you cannot read it, it's very blurry, but I have sent it over, and Kay can, I think, send it out, put it up on EADS should you want to use it. And then the most easy way to get it is just to Google Adult Preventive Health Care Schedule 2018 AAFP. It will pop right up. You'll see this blue, green, and yellow chart, and it will encapsulate all of those preventive health interventions plus a couple of extra things. It gives you behind there a page of risk factors for HIV, the hepatitis, syphilis, chlamydia, gonorrhea, tuberculosis. Tells you about breast cancer risks and about BRCA mutations. Gives you then in the next 2 pages all of the U.S. Preventive Task Force in text, rules about who would need to be screened. And you know that when your patient gets to their primary care doctor, they're going to be reviewing something like that. So the point here is that screening leads to preventive therapies and health promoting counseling, which are, kind of also placed on here to give a guideline as to what might be useful to counsel for. It's all on one page, and all adults should have an opportunity for this screening. Why is it important for us to advocate for this? Well, part of the reason is our patients that don't think about acquiring other health care for themselves. And another reason is that the primary care screening and health maintenance really does need help, that it's not foolproof, and it often is accomplished when you have a patient that knows what they're supposed to get and is going to ask for those things. Sometimes even asking for one thing will start a cascade where they'll get the rest of their preventive care. But here's what happened. The CDC found that there are gaps in physicians' knowledge of ovarian and colorectal screening, significant non-adherence regarding cervical cancer screening, smoking cessation counseling documented only in 21% of visits where tobacco use is mentioned, and that we know that our patients may lack the health literacy they need to be able to advocate for themselves or to meet their own needs. So when we can promote for our patients, and when we can coach our patients to ask for this kind of screening they need, it helps those overburdened primary care doctors to fill in the gaps and to do things the way that they should. We would like to keep it simple. However, as the AAFP notes, the gap between guideline recommendations and actual practice has the potential to worsen as recommendations become more complex, vary by age group, and increasingly require risk assessment. So, if you look for that document, there's a whole couple of pages to help us get through the who's at risk for what and who might need to have extra screening, and that this is something that I say, nobody else, but that MAT providers can enable health promotion by empowering and encouraging patients to know what they need and to be able to ask for that. Thinking about health literacy, that one component of health promotion. So, kind of a bare bones definition is that it's the ability to obtain, read, so we have to think about literacy for our patients, general literacy, to understand and to use healthcare information in order to make appropriate health decisions, and to follow instructions for treatment. That's what health literacy is. And here are some take-home points that we can give to our patients whenever we have the opportunity to, that help to expand our patients' health literacy. MAT clients deserve health care and have a right to be respected by healthcare personnel. If you go and see someone and they're, suspicious of you because you're in a buprenorphine program, or they're not wanting to treat you, or they're not wanting to talk with you about anything else except whether you're going to try to get opioids from them, that's not a person who's respecting you and who's going to meet your needs. Move on. You've spent an hour, move on until you find that healthcare provider who's going to really be able to have a relationship with you. Health can improve even if neglected in the past or bad now, and small changes can lead to bigger changes. So that kind of on and off thinking, black or white thinking, either I'm totally healthy or why bother, and to, as people move into recovery and are able to tolerate ambiguous situations or situations where they're not getting everything they want right away, we certainly can see that expanding to healthcare. I may not have all of my healthcare goals met, but I can stop drinking a Monster energy drink with sugar in the morning and instead have a glass of water. Small change leading to a bigger one at some point. And having our patients understand that they can make changes that are helpful for themselves, and they actually can provide some self-care for themselves. Patients can be treated with, pain can be treated with medications and procedures that don't require opioids, and choices exist. So sometimes a patient has pain, and when you ask, what are you doing for your pain? Have you seen your primary care doctor? You have pain management? Oh, I can't have any of that anymore because I'm over here with you getting buprenorphine, so I just got to suffer through my pain. So that's a patient that really doesn't understand that even though in the past, their main goal might have been to scam opioids from a pain doctor or primary care doctor. That's no longer their goal. Their goal is to function in life, not just to control their pain, but to control their pain so that they can meet other goals in their life, pick up their grandchild, sit through a meeting without having to get up and walk around. Patients often don't have that health literacy to know that pain management is a lot more than just getting an opioid, and that they're entitled to that and may benefit from it, and that clients have a right to information and a right to make choices about their healthcare priorities. Sometimes I might think that there's an issue that's the most important for a patient to address, and I'll share that with the patient, but for them, it's really important for them to do something else first, and that's okay for them to have different priorities than I do. There again is our model of health promotion, good governance, healthy cities, and health literacy, the three pillars of health promotion. And I'm just going to conclude by reflecting a little bit on what does health promotion mean for us as MAT providers, and that health promotion is for us too. When we think about good governance, We can think about all of those bodies that help us to know our literature and to work with the best evidence-based practices. Even though we have a lot to say about the Ohio Revised Code, at least it's there and it's clear for us to know, what do we need to do, and we have ways to comment on it when we need to. If we think about healthy cities, the components of that are being able to appreciate nature, culture, and all of the kind of life aspects and events that helps us to have health-sustaining behaviors. And, it's very possible for us, especially if we've undergone a bad situation with a patient, someone who's died of an overdose or who's left our program, to really forget that there's life beyond substance use disorder, not only for our patients, but also for us, and to be able to put our work aside and enjoy some of these things that add to our quality of life and our family's quality of life. And then this issue of connecting others to get the things that we need. Providers, patients, and other advocates are there for us to connect with when we're feeling isolated, or that we're really need to have some more support and input. What about our own health literacy? We can think about, what are our own health maintenance needs? Are we attending to those or putting them off? Are we attending to our own wellness, that feeling that, we like to get up in the morning and come to work, even though there are going to be frustrations or disappointments at some times? Do we have a sense of meaning in that job, and what do we need to do to have that? And then to be able to allow ourselves to occupy the patient role when we need to, because that certainly could happen. And with that, I think, I'm not advancing, but I think that's the end anyway.
You have to click on the slides with the mouse.
So you think you're
There you go.
Yeah,
Oh, there you
so
go.
there we go. There's just some references for you to use if you would like to, and that document that we'll have available on Eads and send out.
Nice. Thank you so much, Sybil.